inequity. We are going to start live streaming and recording now. And first of all, I'd like to have the director of CRCS, Milind, to give a few opening remarks, and I'll take it from there.
Welcome to Circus, our Harvard Center for Research on Computation and Society. It is exciting to host this panel on what is the role of AI in health equity. My name is Milind Tambe, Director of Circus CRCS. Circus Center focuses on use of computation for public health, conservation, equity, and fairness, essentially computation for social impact. In addition to projects, we host events such as this exciting panel, as well as seminar series, Rising Star events, and others. I wanted to thank Shalmali Joshi for putting this together. And with this, I'm going to hand this over to her to introduce the panelists and kick off the program. Thank you so much.
Thank you, Milind. I just want to give a little bit of context on why we actually came up with the panel this way. As you all know, we at CRCS or Circus are essentially folks with expertise in computational methods and try to apply it in problems of social impact, starting from public health, conservation, clinical health, and issues of algorithmic bias. Most of the times, these days, technologies like AI are the ones that are broadly construed, are the ones that are having this kind of direct impact on social challenges. And some of the times, those are not necessarily the most beneficial to society. And in fact, there's documentation of evidence of harmful impact as well. So if we want to have actual real impact, which is beneficial to everyone, we want to learn from experts who have already critically engaged with such technologies, and who else is better to talk to than our colleagues at the Harvard T.H. Chan School of Public Health. It's also important for us to understand the historical context of health inequities and what is the state of inequity, how we came to this place, and where we should take our technology to do better. So that's why we also have experts in history of science and we hopefully will get a very diverse perspective on how these technologies can actually become beneficial. So the way we'll do this panel is, the session is first we'll have all our expert panelists give a talk. I will introduce all of them briefly, and then all of them will give a talk, and then we'll have some clarification questions in the end. And then with respect to the talk, and then we'll move on to a more informal discussion session where we'll have specific questions that we have for panelists. But at that point, we'll essentially open this up to all the attending audience. If you have pressing questions you want to ask the panelists, please feel free to send it in the chat or raise your hand, and I will specifically ask you to ask the question. So with that, let me introduce our panelists, and then we can start our talks. Our first panelist is Dr. Heather Mattie. She's a lecturer of biostatistics and the co-director of Health Data Science Master's Program at the Biostatistics Department at the Harvard T.H. Chan School of Public Health. She teaches several courses, including Introduction to Data Science, Reproducible Data Science, and Deep Learning. Her research has focused on the intersection between biostats, data science, and network science. She has used network science and machine learning to study interactions in communities, as well as development and application of AI for healthcare research specifically. She is also very interested in the notions of algorithmic bias, specifically on algorithms compounding inequities and working against underrepresented and disadvantaged groups in society. She has also found, in her research, she's found links between unhealthy weight control behaviors and the use of mobile dating applications, particularly for racial and ethnic minorities. She's also developed methods that predict network strength, tie strengths in the network, which assist in modeling spread of disease and information. She's also examining the potential for AI to actually improve inference from data for care and population health, as well as challenges related to bias and scalability of such methods. So welcome, Dr. Mattie. She'll be talking about algorithmic bias in healthcare. Our second panelist is Dr. David Jones. He is trained in psychiatry and the history of science. He is the Ackerman Professor of Culture of Medicine at Harvard University. His research has explored causes and meanings of health inequities in his book on rationalizing epidemics, meanings and uses of American Indian mortality since 1600, and decision-making in cardiac therapeutics in his book on broken hearts, the tangled history of cardiac care. He is now pursuing 3 new projects on the evolution of coronary artery surgery, heart disease, and cardiac therapeutics in India, and on the threat of air pollution on health. He teaches the history of medicine, medical ethics, and social medicine at Harvard College and Harvard Medical School. He's going to be talking about his recent work called Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms. So welcome, Dr. Jones. Our third panelist is Dr. Nathaniel Hendricks. He is a postdoctoral research fellow in the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. His past training is in pharmacy and health economics, and the focus of his fellowship is cost-effectiveness methodology, which he studies under the supervision of Dr. Stefan Vergwe. His research in AI is in 3 main areas, using conjoint analysis to study stakeholder attitudes towards clinical AI, leveraging simulation methods to inform clinical translation of AI-based risk scores for cancer screening, and developing methodologies for performing cost-effective analysis on AI-based clinical tools. And he'll be talking about some of the analysis he's done to support equitable implementation of clinical AI. Welcome, Dr. Hendricks. With that, Dr. Mattie or Heather, can you share your screen and we can start our talks at this point?
Thanks for the amazing introduction. All right. Perfect. And when I gave this talk before, it was a bit long. I had 45 minutes to an hour, so I may go a little bit quickly over some things. But if you would like access to the slides, I provide links to my references. I can absolutely share them with everyone. So really quickly, you just did a fantastic introduction, but I have to give a shameless plug to the Health Data Science Master's Program. If you're interested in that, you can also email me about that. It's a fairly new program that started in 2017, so got to get the word out there. And I'll start off with what is algorithmic bias, and I'll kind of extend that to algorithmic bias in healthcare and medicine. If you've heard of algorithmic bias termed algorithmic fairness, we're talking about the same thing. It's just the more optimistic view of algorithmic bias, but it's basically anything that, any kind of algorithm that is biased against some group over another. These can be, across racial groups or class groups. It's any kind of different groups. So basically just where, is your algorithm being unfair towards one particular underrepresented group. We've seen a lot, especially lately, a lot of examples of algorithmic bias in the public eye now that people have kind of discovered this. There's more publicity around it. There's more studies to try to find algorithmic bias. This is one of ProPublica's more well-known stories about the US judicial system being racially biased with their recidivism risk scores. And again, I provide links to these, so I'm just going to go through these kind of quickly. There's bias in the ads shown on Google, Amazon recruiting tool, credit scores. It just tends to crop up in every kind of aspect of life. Some consequences are worse than others. But again, we care about healthcare and medicine, especially for this panel. So really, and this comes from a paper I co-authored with other HSPH alums, but we define it as algorithmic bias that occurs, within healthcare that kind of exacerbates inequities in race, background, religion, gender, any kind of difference between groups in regards to kind of health systems or healthcare and medicine. So there are now there's now more examples of how algorithmic bias can pop up in healthcare and medicine. And I provide a few of these again with the links to them. There are a few racially biased risk scores. And they, these models kind of reflect the data, but also biases in medical decision-making, access to care, quality of care. And so they just kind of compound inequities that already exist in society and kind of perpetuate these inequities through their decision-making or their predictions. This is another one with length of stay, which was racially biased. Genetic, this happens in clinical trials too, but with a lot of the genome mapping studies, most of the individuals in those studies were of European descent. They've started to try to balance out representation, which is great. And so have clinical trials, but those are two very big examples of kind of an imbalance in representation of who's represented in the data, and therefore who do we have more information about and can make better predictions for with our algorithms. And I have this, I should probably add a step 0 before this in who gets to actually design the study and collect the data, because that's also part of the process. But in this whole kind of, creating and implementing an algorithm pipeline, where can bias kind of crop up? And I'm sure everybody probably knows it's basically anywhere in this process. So you can have bias in the data, you can have bias in the people creating the models or collecting the data, cleaning the data, and then implementation itself. So it comes in various forms, but it can come from every single part of the process. And so recognizing where it can crop up and then how to detect that is part of the process of kind of mitigating this bias. And so how do we fix this? In my paper where we define algorithmic bias for health systems, I kind of outline these more in detail, but just a few kind of main categories for how to attack this. One, be cognizant that this is an issue. This is a very prevalent and life-changing issue. Like I said, people are becoming more aware and doing more studies into algorithmic bias in healthcare and medicine, but we still have, a lot more research to do. But just knowing that this is a problem and kind of looking out for it is definitely the first step in this process. The next one would be data management. Again, it's a lot of things, but have a representative sample, make sure you're thoroughly documenting your code, your protocols, your process. Transparency and reproducibility are really, really good ways to, make sure that, if somebody else sees what you've done, maybe they'll pick up on something that you didn't notice. And so it'd be a quicker way to, go back, and fix it, or just bring it to your attention and let everybody else know. But I'm just a big proponent on transparency in the entire process, as much as you possibly can be. Choice of algorithm, this, you need to make sure that model assumptions are met. You're using the appropriate model. you're using appropriate measures of performance. A lot of papers, understandably, will say, my model performs the best and use this particular performance metric like sensitivity or specificity or something. And that makes it look great. But they fail or neglect to mention where their algorithm goes wrong, what that means. Is it worse for some more than others? And so being kind of, again, more transparent about what your model does well, but also where it's making its mistakes and what that means in the general context of implementation is another way to just be kind of open about where this bias can crop up. That's more of what I just said. Basically, these mistakes, even though they might look small, like a small 1% error, for example, that can affect millions of people. And so in healthcare and medicine, you are scaling these algorithms up and affecting more and more people. So that's why it's such an important issue as well. More on transparency, again, kind of literate programming, this goes hands in hand with what I said before. Also, report the generalizability of your model. If you trained on a certain population and you're implementing it on a population that does not resemble the training population, there's going to be issues. It's not going to generalize well, it won't perform as well, and that can lead to problematic decision-making. And then finally, I don't think this is thought of as much as it should be. Maybe it is more now, but having diverse teams of people throughout the entire, process and pipeline, if you can, and this can be in terms of race and class, this can be educational background and training. Every individual views the world from a different lens. Everybody can give you a different point of view and spot different forms of biases that are creeping in. So the more diverse your group of people creating this and implementing it, in theory, the better you will be at mitigating or recognizing any biases that are creeping in along the way before you actually implement anything. So finally, humans are biased. we just are. We're fallible. Bias can come in from humans in the process. It could come in from the data in the process, and we saw the whole pipeline. But again, recognizing that it's a problem, trying to mitigate it along the way is going to be really, really helpful. It's not possible to eliminate all of it, but it's definitely possible to remove some of it and make algorithms better and more equitable. And that's all I have.
Thank you for that, Heather. David, do you want to go next? You're muted.
I hope my comments will complement Heather as well. So thank you for the invitation to speak. Sometime I hope to see you all in your brand beautiful new campus in Alston, but obviously not today. So there's much to say about all of these topics. Like Heather, I could go on for much more than the 10 minutes I was given. So I will touch on many things briefly and will be happy to take questions about any of this afterwards. One of the topics you asked me to think of this in terms of is what has happened with COVID. And one of the tragic features of this pandemic has been its hugely unequal impact on different populations throughout the world. You can see this on a global scale, with the cases and deaths so far concentrated in the United States and Brazil, compared to more or less complete control in Taiwan, China, New Zealand, or others. And you can see this within the US, both the shifting geographic focus over the past 15 months. I saw today that half of the deaths are now confined in 5 states. Massachusetts currently isn't one of them, but I think would have been the 6th state on that list. but most tragically in terms of race disparities. And there have been persistent disparities 2 to 3-fold higher mortality in Black and brown people in this country. Now, I approach this in part as a historian, and from the point of view of a historian, these race disparities are probably the least surprising aspect of the COVID pandemic, if only because they have been one of the defining features of all past epidemics, with very few exceptions. But epidemics almost always have an unequal impact on people in society. They almost always strike the poor and marginalized most severely. And so I suspect that social scientists will be busy for a generation trying to sort out exactly what happened. And I assume that people will continue to be feeding data into machine learning algorithms to see if the machine can figure this out better than we can. And this will need to be done with great care. In part, it's important to understand when and where the disparity is actually coming from. Because it's very easy to be misled by analyses of the data if you're not thinking carefully about them. As far as researchers can tell now, and this is just a provisional answer, the race disparities we've seen in the US reflect differential exposure to the virus, not differential susceptibility once exposed. And of course, differentials in exposure are really socially determined. People in high-risk essential industries or people crowded into multi-generational homes seem to have been those who have been most at risk. And the particular risk factors are population specific. So colleagues at the School of Public Health, for instance, showed that while risk has been elevated in both Black and Hispanic populations in this country, each group has slightly different sets of risks. There's one set of risk factors for African Americans, one set for Hispanics. And I suspect as people zero in on this data, they'll realize there's huge geographic variations. So in one city, there'll be one set of risk factors for one group and another set of risk factors for another group. And those risk factors will vary from population to population. And it gets even more complicated when you look at both sex and gender at the same time. In general, for COVID, mortality has been higher in men than in women, but not across the board. So for instance, mortality in Black women has been higher than mortality in white men. My colleague, Sarah Richardson, in History of Science and WGS, recently published a fascinating report about this problem, highlighting the impact of intersectionality on risk during this epidemic. And so one lesson for those of you who are doing these computational analyses is that we will clearly need to have sophisticated analyses that can capture the subtleties in the data. This will require input data sets, and this is very early on Heather's to-do list for how to do this well, but really good input data sets that capture every relevant aspect of diversity, not just race and ethnicity, but also questions like employment, housing, income, wealth, and all of the other factors that figure into this. And if you don't have all of these measures in your data set, there's no way you're going to get an optimal outcome because you're analyzing an incomplete picture. Now, of course, if you want to try to get this comprehensive, all-knowing data set, that's inevitably going to raise questions about privacy and surveillance. And I don't have any easy answers as to what to do about that. This raises the second question. And this intersects with what Heather was talking about is, well, what do you need to do for AI and machine learning to work well? And so that gets to this question of algorithmic bias. And so this is one of the studies that Heather mentioned, the study by Obermeyer et al. And let me just say a bit more detail about this so you can understand where this went wrong. And so the goal here was to develop a clinical tool that would predict what patients are at high risk medically over the next 6 to 12 months. And the researchers whose tool was analyzed guessed that patients who had incurred medical expenses recently were likely to be sick people. Why else would you be going to the hospital? And so they figured past healthcare costs into their prediction of future risk. And there's nothing inherently wrong with that approach. It makes good sense, except medical spending in the United States is racially stratified, with more money being spent on white people than Black people. And so this algorithm ended up selectively identifying white people as the people who needed more medical attention. And this then becomes a positive feedback loop. If you were to follow this advice, you would then spend more money on white people, such that white people would always be seen as high risk, and you'd be told to spend more money on them. And this would go on and on and on. Now, there's an interesting subtlety here. Whether it's good or bad that this algorithm led more healthcare resources to be spent on white people depends on how you feel about the problem of overuse of medical interventions in the United States. it could be that a racist algorithm like this was actually protecting Black and brown people from excessive intervention. But this is one example of a much broader problem of what happens when race is encoded into medical tools. And this goes back far before the world of machine learning and artificial intelligence. One case has been much in the news recently, the problem that pulse oximeters have. It turns out they were optimized for use in pale people like me, and they underperform in darker skinned people. Engineers had been aware of this for decades, but hadn't been concerned enough to do anything about it. But when COVID made pulse oximetry more relevant than ever before, in the context of heightened racial sensitivities, this problem has become a bit of a scandal. The person who really brought it to public attention was an anthropologist at MIT, Amy Moran Thomas, who published a terrific article last summer. And that tipped off some medical researchers who confirmed the problem with a letter in the New England Journal of Medicine. And then just this past week, the journal made an interesting decision to publish a critical response from, I think, essentially an MD PhD student in England who asserted that medical devices are blind to color and cannot exhibit such a bias, to which the authors basically said that's like the dumbest thing ever. Of course, a technology can be biased if it was designed by biased people or implemented in biased ways. But again, whether this bias actually harms people depends on this question of overuse. It could be that pulse oximeters that were insensitive in dark-skinned people may have spared those people from the overuse of ventilators in the early months of COVID, which proved to be a toxic intervention. Another category where there has been a lot of controversy has been this issue of what's called race norming, which is you conduct a diagnostic test on people, but then use different norms to evaluate deviation from normal for people of different races. This has been done for pulmonary function tests for decades. It has recently gotten the National Football League into hot water because it has been forcing neuropsychologists to use race-specific norms to assess people who have sued the NFL for settlements for occupational concussions as a football player. Now, with each of these, there is an empirical basis. You can point to studies showing that the norms are different. The question is whether those data are robust. And if the race-based norms reflect some kind of racist structuring of society, as was the case with the medical spending, then the use of those race norms will just perpetuate this. And so we need to be really, really careful before these things are used. And then there are a series of tools that I described in the paper I published last summer that don't race norm, but essentially what they do is that they use race correction factors. So they use the same diagnostic test and the same standards, but they insert a coefficient to adjust the results of the test according to race. Some prominent people argue that race norming and race correcting are different practices. They really aren't. They have exactly the same effect computationally. Building race into these algorithms and causes problems. So why does this matter for all of you who are doing this computational work? So my focus here is, again, very early in Heather's list of steps, is that it's the structure and the content of the data that you use to train algorithms are really, really crucial. Well, it's certainly the case that the race categories that we use are arbitrary social constructs. Race and racism are powerful social forces in society that shape the distribution of valuable resources in racist societies. So you don't want to ignore them. No race critic I know has ever called for a race-blind medicine. It just wouldn't work. But the question is, well, how do you consider race without having these kinds of race bias in the algorithms? I was talking to some researchers at Stanford who pointed out that even if you had a huge data set and you just deleted the race column, that's not going to work because many of the other columns in that data set correlate with that race. And so even if you remove it, it will persist as a ghost. And so I don't know how to solve that problem. I hope that you all have clever solutions for that. In our article last summer, what we argued for was keeping race in the descriptive statistics of medicine so that you can know what's going on, but to be really, really careful using any tool that embeds race or ethnicity into predictive algorithms, because that's where you can get into the self-reinforcing feedback loop. And the other thing to be really careful of is the categories that are used. One of the problems in many of the clinical tools is that they rely on really simplistic markers of population diversity. Many of them just divide the world into Black and non-Black people and leave it at that. Some upgrade that and use the US Census categories, 5 races, 2 ethnicities. Neither of those is an adequate parsing of human population diversity. And so in some sense, any data set or tool that relies on these categories isn't going to be able to function well because the categories themselves are so impaired or so limited. And then meanwhile, while medical researchers tend to obsessively collect data by race and ethnicity, they've done a terrible job collecting data sets to incorporate measures of socioeconomic experiences. Epidemiologists do a bit better than clinicians do, but it's really a problem. Most clinical trials that get published include data on age, race, and gender. They don't include anything about income, education, environment, or housing, or if they do, they do so in very simplistic ways. We need to figure out much, much better ways to capture in our data the wide range of exposures that people experience, and ideally not just a single snapshot in time, but somehow an integral of these exposures over people's lifetime. And only if you have really good data like that can you possibly come up with algorithms that are going to solve the problems that really matter to us. And so people will object and say, well, that will be really, really hard to do. To which I will say, yes, but we've accomplished many difficult things in the past. We sent people to the moon and brought them home safely. Our colleagues at MIT and Harvard have developed both of the vaccines that US researchers have developed for COVID in the past year. We have invested massive amounts in genomics. And I think if we were to commit similar resources to this problem of how to figure out adequate socioeconomic characterizations of our patients so that we could collect better data sets, then all of you in the world of AI and machine learning would be much better equipped to answer these difficult problems. So I will stop there.
Thank you, David. That was excellent. Nathaniel, do you want to go next?
Okay, so as Shalmali said, I'm a health economist by training, and so I'm going to be talking to you today about cost effectiveness analysis, which is very much the bread and butter of my field, and how it's changed in the face of increasing acknowledgement of inequities in our healthcare system, as well as the birth of clinical AI. So I'll start out first by discussing what is cost effectiveness analysis. And at its heart, cost effectiveness analysis is really a model of the natural history of disease, plus maybe the transmission of that disease, with a couple modifications that allow us to extract from that model the overall health outcomes that emerge from it, as well as the costs. And so by running the model with different interventions, we can get the relative value that emerges from them. So usually our disease model will consist of a set of health states. And in this case, we've got a very simple disease. Patients start out well, they may become sick at some point and may progress to the sicker health status. They might be cured or they may die from the disease. The advantages of modeling a disease like this are many, but one of them is that it allows us to extrapolate trial results over time. So if we only have 2 years of observed data, for example, using a model like this and including inputs from the literature, from other data sources, would allow us to extrapolate that out to maybe 10 years of observed time. It also allows us to extrapolate trial results to different populations. And so if there is a population with different risk factors or different rates of progression, for example, we could estimate the effect that some intervention might have on that. And then finally, very relevant to AI, it allows us to estimate the clinical impacts of interventions that really have only told us their performance, how their performance is. And so we can take, for example, a diagnostic AI, take its sensitivity and include it in a model like this and estimate its clinical impacts. So the way that we usually extract our health outcomes and costs is by attaching to each of these health states an indicator of quality of life, as well as costs. And so you can see that, of course, the patients in the well health state have the best quality of life. The ones in the sicker have the worst quality of life and are the most expensive as well. And so you can see how by modifying the rate of movement from one state to another, we could lower the costs and improve quality of life. But this model, even though it's relatively simple, it allows us to get from it a number of different health outcomes that include things like time spent in good health, overall quality of life, total deaths, and years of life lived. It also allows us to extract different sources of costs. So we can extract from this the healthcare system costs as well as patient costs. Thinking about where AI fits into this, I think it's essential to note that from an economic perspective, we don't really need to know how AI was built. We don't need to know the algorithm that it's based on or anything like that. What we do need to know is what influence it might have on our simulated patient's journey through these health states. And so a diagnostic AI, we might say, if that's better than a human clinician, we might say that that's going to promote earlier diagnosis and promote survival that way. And then by using this model, what we could do is help AI researchers by finding a location on the ROC curve that will optimize health outcomes. So finding the optimal trade-off between sensitivity and specificity, for example. If we were analyzing a decision support tool, we might suggest that could slow progression by helping clinicians to make better decisions. But we could also integrate behavioral research about how clinicians respond to AI, as well as other factors, and maybe use this model to indicate when it's good to use AI as decision support and when it's good to have AI making all of the decisions and to essentially replace a clinician that way. And then one more scenario, if we had an AI that was automating our disease monitoring, that would help us lower the costs that were associated with illness. And using this model again, we could test different frequencies of monitoring, different thresholds for alerting clinicians, and so on. So as we talk about how cost effectiveness results are analyzed, we usually use a two-dimensional plane that we refer to as the cost effectiveness plane. So on the x-axis, we've got overall survival, and on the y-axis, we have costs. Our outcome doesn't need to be survival. It can be quality of life. It can be number of cases, anything like that. But the important thing is that this is always going to be incremental compared to our standard of care, which lies at the origin. And so if we plot a hypothetical intervention here, we show the number of life years lived compared to our standard of care and the costs also compared to the standard of care. And by plotting it like this allows us to interpret the slope of that line from the origin to our intervention as the incremental cost per life year gained. And that helps us make decisions about it. So in many places, especially in Europe, they'll have an explicit willingness to pay per life year gained. And so if we plot this on our cost effectiveness curve and our intervention is below that line, we would accept it theoretically. And if it were over, we would reject it. But the thing that you might be noticing is that this really only includes efficiency. So this is measuring only how our costs translate into improved survival for our patients. And efficiency is certainly a very important issue, but it is not the only one that people care about. And so to remedy that deficiency in cost effectiveness analysis, we're starting to see more of what we call extended cost effectiveness analysis. And this is a way of integrating distributional effects of different interventions, as well as including some of the other sources of value that we might want to consider. So the way that we do extended cost effectiveness analysis is we run this disease model separately for each subgroup that we're interested in. You often see this for income quintiles. So we would run the disease model 5 different times, once for each income quintile. And so we get from that the health outcomes per group. So we see the distributional effects of our intervention. And we also can take from that financial outcomes. And we use that as a goal because financial outcomes are another source of value. So helping people to stay out of poverty due to medical costs, helping them to avert catastrophic expenditures. These are important goals of healthcare, and so we can assess the efficiency of different interventions in doing so. So this is from a paper looking at tobacco taxes in China, and you can see the distributional effects of this intervention on survival. We have the poorest income quintile benefiting the most and the richest the least. So in terms of outcomes, this is a pro-poor intervention. And we can see here, based on the amount of, or excuse me, the change in tobacco spending, that this is also a pro-poor intervention, that this is saving them money by doing this. Again, we see distributional effects here, and this allows us to confirm that this is a pro-poor intervention. So I want to wrap up by talking about a couple challenges that AI has posed to traditional cost effectiveness analysis and extended cost effectiveness as well. So a lot of AI papers don't give us data on subgroup performance, but I've included a couple figures from a paper that does. And I think they did a really great job here. So this is from a paper that compares a deep learning algorithm for predicting future breast cancer risk based on mammography to a clinical calculator that includes only demographic factors, family history, and so forth. And in these graphics, we can see the difference in performance not only between our two interventions, our deep learning and our clinical calculator, but also for different subgroups. And so on the left here, we can see how these two different algorithms perform for white versus African-American women. And on the right, we can see how it performs for pre versus postmenopausal women. And then one more point that I want to make about the challenges of assessing AI is that it's frequently difficult to get information on how much AI agrees with human clinicians. On the left here, I've kind of shown a graphic of a very high performing artificial intelligence. It performs as well as a human clinician. It catches as many cases, we might say. But it repeats a lot of the same decisions that a clinician would make anyway. And so it doesn't really push that boundary out very much of what kind of cases that clinician is going to be able to detect and we're going to be able to treat. On the right, we have an AI that catches fewer cases overall, but it catches more of those cases that the clinician doesn't miss, or excuse me, that the clinician does miss. And so even though it's a lower performing AI, we might say, it might provide more value. But this is really not talked about very often in AI papers, and it's been a challenge as health economists have started to do cost effectiveness analysis on AI. And with that, I'll wrap up. Thank you.
Great. Thank you for those excellent talks. If folks have questions, I'm going to start opening that up for Harman. Do you have a question? Or okay, that's just applause for the panelists. Those who have questions, please just let me know now or send them in chat. I have lots of questions for all the panelists, but I'm going to wait for the audience to chime in as well. Okay, while we wait, my first question was for Nathaniel. You talked about these cost-effective analysis, and we just discussed that maybe we want these intersectional identities when we are looking at cost-effective analysis. Does your analysis depend a lot on like the number of samples run through? Because when you look at intersectional identities, then you're not going to have enough samples to have. Does it introduce bias in your estimates? Have you seen a loss of accuracy when it comes to estimating outcomes and costs for different subgroups?
I think it definitely will depend on the subgroup size. So we even saw that in the ROC curve from that breast cancer study. we saw that the population that they used was primarily a white population. And so the performance on the for the African American women was, the resolution was not as smooth, right? It was a very sort of stair-step curve. And so it definitely depends on the sample size. At the same time, the field of cost effectiveness analysis, or excuse me, health economics, has developed some pretty nice methods for assessing the role that uncertainty plays in our decisions. And so and then, put whatever kind of uncertainty seems reasonable around that estimate to see how that affects our assessment of value and whatever recommendations we might make about implementation.
Well, and one thing I would add to that, again, is just how hard these problems will be to do well. So that today, the Wednesday seminar in the Department of Epidemiology was by the guy who's the principal investigator on the Jackson Heart Study, which was an analog to the Framingham Heart Study, but instead of enrolling white people in Framingham, it enrolled mostly African-American people in Jackson, Mississippi. And he's now doing a similar study in Atlanta. And he just kept peeling back the layers of the onion. So over the course of the 20th century, it has emerged that there are significant disparities in cardiac outcomes between Black people and white people. So when they were looking in Atlanta, they realized that if they stratified for socioeconomic status, the situation looks very different. So there are differences between poor Black people and wealthy Black people. And so then they looked at neighborhoods where they were comparing different types of more or less poor Black people, and they found significant disparities basically based on the social capital within these neighborhoods. And so every aspect that they looked at gave you more and more insight to what was going on. But of course, as you're doing that, you're shrinking your sample size smaller and smaller and smaller. And so I think some people hope that somehow if you have huge enough data sets and supple enough deep learning algorithms, you'll be able to extract useful information even as you partition the population into smaller and smaller and more specific subgroups. I don't know if that's a reasonable hope, but it'll be interesting to see how this develops.
Yes, definitely. It also is the case that when we have these data sets on intersectional subgroups, they tend to be noisier for certain subgroups and not. So it really is not clear whether an algorithm can compensate for something like that. My question related was about over treatment that you talked about a little bit. It's a hard question, and I was trying to understand how one might go about establishing what might be happening there. Is it really that there's of course measurement bias that we know of, but are we really at a place where we are aggressively treating patients, or are we really at a place where we might not be treating Black patients or patients of color enough? How would one go about thinking about that kind of an analysis?
So it's an area for which there are very strong disagreements amongst clinicians that have existed now for decades. The one I've looked at most closely is the techniques of cardiac revascularization, bypass surgery, and angioplasty. And really, as soon as these techniques were developed or became widespread, bypass surgery in the 70s and angioplasty in the 80s, it was clear that these techniques were mostly being used in white men. And so there were biases by both race and gender. And there were allegations, which most people, but not everyone, have found convincing that these techniques were overused. And so it has left this awkward ambiguity in how you interpret these data sets. And so on the one hand, you can say it's terrible in the United States that there are a whole series of different modes of bias, such that Black men and especially Black women are less likely to be given access to these life-saving technologies. It's probably true. But it's also likely the case, and some people have done these calculations, how many strokes have African-American men been spared by not being subjected to overuse of bypass surgery, which has a known complication rate of strokes. And you can do those calculations, and it's a non-trivial number. Or, white people often get access to medications first. So when statins were introduced, when statins or any other drugs were introduced, white people often get them first. There was a there was a controversy almost 15 or 20 years ago now about a specific drug, rofecoxib, which was marketed as Vioxx. It was supposed to be this great new non-steroidal anti-inflammatory that didn't cause GI side effects. Well, it turns out in the year that Vioxx was on the market, it was probably the leading cause of heart attacks in this country. Most of that was borne by white people, not Black people, because doctors were racing to give this fancy new drug to their white patients. And so it's really hard to know how to interpret that and what to do with all of these things. But there are some very interesting ways, and let me just share the screen to show you this article. This is one of my favorite recent ones. Again, done in part by people here. So the lead author here was Obermeyer, who was the same author of the study that Heather and I mentioned. David Cutler, who's a health economist here, was also on this. And so there's been this longstanding concern about differential treatment of pain in the emergency room, with white people generally being given access to more pain medicines than Black people. And so to understand that, people had done many studies in the past where they would have radiologists look at an X-ray and rate the severity of joint damage that you could see on this X-ray. And when they did these studies, they found that, the initial interpretation, when you see that Black people aren't getting pain meds in the ER, the classic interpretation has been that somehow ER staff are being mean to Black people and not giving them the pain medicines that they need. There were all these studies that were done in response to that showed, well, if you systematically have radiologists rate joint trauma on X-rays, it turns out that for a given level of trauma, Black people were reporting more pain. And so the insinuation was that somehow Black people were exaggerating how much pain they were in, maybe in some kind of ploy to get more pain medicine. And so this literature served to cast doubt on both Black patients and the significance of this. I'm puzzled why anyone would do that kind of research, because it's very pernicious research. So in this paper, Machine Learning to the Rescue, what they did is they had a machine learning algorithm come up with a way to rate pathology on joint X-rays. And it turns out if you have a machine learning algorithm rate joint pathology, it produces different scores than the human radiologists had done. And those scores are actually much more predictive to the actual pain that was being reported by these Black patients. So which raises this interesting question: who is better at rating joint pathology, a human radiologist or a machine learning algorithm that doesn't even really know what it's looking at? Well, you could say, since the machine learning algorithm correlated more closely with patient experience, then yes, the machine learning algorithm is a better rater of joint pathology than the humans were. My sister-in-law is a radiologist, and so I was talking to her about this, and one of the questions comes up, like, if you're a radiologist looking at shoulder X-rays, you're looking at hundreds of them. Like, do you even know the race of the person whose film you're looking at as you're rating this pathology? How does racial bias possibly get inserted into that area? And no one's really sure, but it could be that people are picking up on patient name, which is racially coded in the US. It could be that if you're working in an inner city emergency room, you rate joint pathology differently than if you're working in a swank suburban clinic. And so there are presumably many forms of deep unconscious bias that were leading radiologists to underreport compared to a presumably more neutral computer algorithm, the level of pathology. So this was a case where someone did a clever analysis that I think will have a profound impact on how people think about radiology practice.
Mm-hmm. This is an excellent example. I wasn't hoping to be very optimistic, but this is like one example where there might be some benefit of using an algorithm in place. I do want to, I have one more question for Heather in terms of, like, you talked about who gets to address certain problems, who gets to even like do research on certain problems, what gets funded is a very big challenge here. And do you have any suggestions of how we as individual researchers can actually ourselves collaborate in teams that are more diverse, or like how does one actionably do something about a problem that is almost seems systemic about who even gets to do certain kinds of research?
Yeah, it is systemic too. You know, the research field is, especially in medicine and public health, is predominantly Caucasian. And what's nice is that there's been advances, especially for young researchers of color. The NIH has come out with, I think, specific grants that you can apply for to help increase the diversity in the biomedical research field. We've started a bit younger to get, to make the pool of undergraduate students going into grad school and then becoming researchers more diverse. We have pipeline programs at the school for underrepresented undergrads from all over the country, as do other institutions as well. So I think that's one way, kind of a pipeline, or a way to get your population to be more diverse to begin with. Another way, typically, I don't want to say only people of color are interested in researching people of color. That's not correct at all. But having research funded that's specifically about health inequities and things that what we've discussed that differ by race. Having those things funded more, I think, will draw more people in and make teams more diverse. At least that's my hope. And I think, at least in my experience, having advocates and mentors around you, even if they're Caucasian, which is great, really helping support and the success of students and researchers of color, faculty of color, will, I hope, perpetuate and make teams more diverse. And you can, go out and try to find more diverse researchers as well. But I think it's changing. But also, giving students of color access to higher education, research opportunities, things like that.
Yeah, thank you for that. We have an audience question, so I'm going to first take that, and then we have more questions to go through. Gokul is an instructor and trains human service professionals, and wants to know thoughts on to what extent the use of AI is likely to impact the need for and access to social services, and to what extent in the future social workers should be engaging with AI in their professional practice. What are your thoughts about that? I would appreciate input from everyone. I personally have thoughts that it might, I'm very pessimistic about use of AI, but I want to really have thoughts from all the panelists here. So Nathaniel, do you want to go first, and then we can?
Yeah. I think that especially in the current environment of COVID-19, we've seen telehealth really start to get traction in our healthcare system. And that's made me optimistic about the integration of different data sources. So the use of data on activity from your phone, for example, using the camera to conduct certain visual diagnoses and so forth. So I think that, telehealth has become a potential source of data for future AI. I think that AI will, one, allow healthcare to become more asynchronous. So it's there when you need it, and not 9 to 5 as a lot of healthcare is done. But also it would democratize access to specialists who are very, very constrained in supply. And Right. And so in that way, I think that AI will have a potential, or does have the potential, to improve access.
Oh, that's very helpful to know. Do you have thoughts, David and Heather?
And so I think with any of these things, it depends on how the AI is used. There's been a lot of excitement about precision medicine and how precision medicine will improve everything. Most of the way that precision medicine has been implemented in this country so far has been in terms of genetics. And that's probably not the be all and end all of how you could do this. So if you were to have a broader vision of what you could do with things like AI and say, well, could we use these huge data sets and sophisticated analyses of them to better identify people who would benefit from social service interventions? Could we identify, where are the opportunities? What share of the burden of disease is amenable to a good social worker? I suspect a lot of it is. But right now that's hard to characterize because most of the data sets that we have are impoverished in terms of socioeconomic markers. And so if we could generate better data sets and come up with better analyses. And so for instance, when you're discharging a patient from the hospital, many of the hospitals are trying to figure out who's at risk of relapse and then try to put services in place, wraparound services to support that person to decrease the risk of relapse. Right now, those assessments are based on sort of very primitive intuition kind of things like, well, we think this person is going to be non-compliant. And so let's send a visiting nurse to check out the situation. Or this person is homeless. Call the social worker to figure out how it's going to be safe to discharge a patient to the street. Well, I think there's a great opportunity with good data sets for clever data scientists to figure out a much more nuanced way, a much more precise way to look at the patient characteristics and figure out who really does benefit from the kinds of skills and resources that social workers have access to, and then target those interventions appropriately. I'll put a link into the chat. One of my colleagues at Children's Hospital, Eric Fliegler, has developed this tool, Health Steps, and which has now been picked up by the Boston Public Health Commission. And basically, it's a web-based tool that is in some ways, it's an old-fashioned tool. What you do is, as a patient, you enter, it asks you a series of questions about challenges you're facing in your life, about housing or income or food insecurity or anything else. And if you screen in positive for any of those things, it says, here's a list of 5 service agencies in your neighborhood. I suspect you could do that tool much, much better if in the background you had a much more sophisticated algorithm doing those kinds of analyses that would come up with better pairings between those people. So I could imagine an upgraded version of Help Steps being a really valuable resource for social workers. You meet a client in their home, you collect a lot of information, you enter that information into a web tool of some sort. There's a complex analysis, and the algorithm with your own intuition would help you figure out what's the most useful thing to do for this family. And so again, I think there's great promise if the tools are designed well.
Mm-hmm.
And I would just, sorry, go ahead.
Go ahead.
I would just quickly echo what David and Nathaniel have already said. But I do think it will increase access to care. If it's done correctly, access to quality care. And I think implementing it it'll take some time, but it's definitely possible and it could be good. It has promise, as David said. It's just implementing it well and ethically.
Makes sense. Thank you for that. Some of us here are also interested in like community-based approaches. And so what that involves usually is telling communities to each other, like who's similar to you, having certain similar issues. And then, but that also has the trade-off of like exposing their private protected identities. What do you think should be the trade-offs that we should consider when we are addressing these kinds of problems? Does anyone have thoughts on that?
In some ways, that's the age-old question of privacy in the data age. I enjoy the fact that if I go to Amazon or Netflix, that has these predictive algorithms that have uncanny, not perfect, but are sort of uncanny in how well they work. If you stop and think about it, it means that somehow they're mining your privacy. Well, if people are willing to tolerate those kinds of privacy breaches to optimize their movie viewing experience, can you convince them to tolerate such privacy? I don't want to say violations, but such information sharing to improve their health outcomes? You hope they would. I can imagine it being a hard sell, though.
Nathaniel, do you have thoughts on that?
Yeah, I was just going to say, I think that, you know, one of the most difficult aspects of, or one of the biggest challenges that we face in doing cost effectiveness analysis in general, is making explicit the opportunity costs of not acting. So I think that in one way, I think, you know, when it comes to trade-offs with privacy, I think we should look at it, one, from the opportunity cost perspective, but also consider different models that are out there, such as allowing people to be paid for the data that they contribute to commercial products and so forth.
Yeah.
I just want to quickly add to that, and again, echo everything that has been said, but understandably, you know, the data is very protected, but if more people had access to the data in a protected way, we could make more advances with AI. I mean, we would have to have that data for populations that don't get a lot of care or have access to a lot of care, so that would still be tricky. But if we can show people that, you know, this is a good thing, this will help a lot, hopefully they would be more understanding of that. And if we had kind of these, I don't know, safeguards or safety nets in place to kind of ensure that we would be using it properly and kind of, you know, safely and not getting breaches or hacks or anything.
Yeah. So a related question in terms of who we share our data with and who we collaborate with. The question I had was, when it comes to like us researchers trying to establish like or develop techniques that are directly addressing some form of inequity, do you have thoughts on whether we should collaborate more with nonprofits, governments, tech companies? What are the trade-offs there? Because sharing data with tech companies is very, very different from sharing data with some other entities. So can you elaborate on that a little bit?
So I would say, for one, I think it's important for computer scientists, data scientists to collaborate with outcomes researchers. The paper that David showed by Emma Pearson was innovative largely because it was trained on patient-reported outcomes. And so I think that there's a lot of potential for improving equity through that means, training algorithms specifically on those patient-reported outcomes. As far as other collaborators go, I think, you know, it's certainly important to talk to clinicians about how they would like to use AI, what they need from AI. But at the same time, we know that there's evidence of bias against AI. There was a paper in NPJ Digital Medicine recently showing that radiologists rated the decisions made by AI in quotes, lower than when they thought that it was from a peer. But the AI was actually a human radiologist. So there was a significant difference in how those were interpreted. And so I think we can provide a carrot for working with AI, but also a stick. And by that, I mean working with payers to see what kind of incentives can be provided for hospitals, administrative entities to implement well.
Algorithm of various sorts. And the question is, can you hold the designers liable, or does the buck stop with the clinician who actually implemented the tool? And in some ways, the physician does need to be held accountable because that's their responsibility is judicious use of these tools. But the concern is if you do that too much and the physicians don't understand these tools, they're going to be unwilling to use anything they don't understand that they're going to then be held liable for. And so how do you provide the physicians the reassurance they need to use these tools that are essentially black boxed to them? And I don't think that's going to be an easy problem to solve. Because in the end, the question is, who's responsible or who will be held accountable for the outcomes achieved by patients? This is one of the big old fights between the fee-for-service system, in which physicians are paid for services provided, versus accountable care organizations, where more or less physicians are paid for outcomes achieved. And if you're paying clinicians based on outcomes achieved, that greatly broadens their horizon about the range of factors that they consider relevant. So for instance, if you're an orthopedic surgeon and you get paid every time you do a knee replacement, you don't really care what happens once the patient leaves the OR. If you're an orthopedic surgeon who gets paid based on a functional score of a patient 3 months post-op, you really care about whether or not they call the physical therapist and follow through with the physical therapy that's essential for their knee replacement to work. I think the healthcare system is moving in fits and starts in the direction of valuing outcomes actually achieved, and that totally transformed the incentive structure. So for the people who are developing these tools, if you can show that these tools actually improve outcomes, then the tools will then become valuable for physicians who are working in that kind of reimbursement system. But there are a whole series of pieces that need to be aligned properly for the system to work as well as it might. And so we're going to need concerted reforms across several sectors of the healthcare economy.
Point. Do you have anything to add to that, Nathaniel?
I'm thinking about how we could incentivize a push towards equity by identifying the institutions that maintain it, and by that I mean identifying cases where, had a patient been served by a different institution, they would have had different outcomes. I think that that's really difficult right now because, as David and Heather have both pointed out, disparities in healthcare don't only show up in the data, they show up as what's not in the data. But I think that there's potentially a role for some of the causal machine learning methods that are starting to be developed to be able to identify when a patient received or developed worse outcomes because of an institution, because they went to hospital X instead of hospital Y. I think that simply having that as a report would be an incredibly powerful incentive. Nobody wants to be known as upholding these inequities.
So you're saying it's a combination of who's held accountable and then an analysis in a prospective validation of where the outcomes might be differing based on.
Yeah, absolutely. So I got my PhD from University of Washington, and in Washington State, we have a great program that shows the efficiency of cancer care, both in terms of following guidelines and preventing infections and so forth. But the essential part of that was that all the different stakeholders were on board with the process for developing it. So I think that it's not something that can be imposed from the outside, but it has to be something where all of the stakeholders have a say in what process goes in towards determining that.
And one of the things that's interesting there, and I think there's a good opportunity, again, for machine learning and with proper data sets, is when people have started making health outcome data publicly available. New York was the first when they started reporting 30-day mortality from cardiac surgery That's now been expanded to other areas, and Massachusetts followed that lead. Physicians initially cried foul because they said, well, if you just do that, that's going to cause adverse risk selection. No surgeon is going to be willing to take high-risk patients to the OR. And so the states more or less said, we'll do risk stratification and trust us that we're going to do that well. So you won't be penalized for continuing to do high-risk patients. And the question is, well, should you trust them? Is there someone who can actually do that algorithm well? So it turns out in Massachusetts, there's a professor in healthcare policy who one of her jobs is to maintain the cardiac outcome reporting system. And a big part of that is continuing to tune and refine the risk stratification algorithm such that physicians who are willing to take high-risk patients to the OR aren't punished for doing so. One of the huge controversies in that area is, do you also stratify by social risk? So people know that homeless patients have worse outcomes, that poor patients have worse outcomes, that underinsured patients have worse health outcomes, that Black and brown people have worse health outcomes. So do you feed all those algorithms in? In some ways, you'd say, well, yes, if you really want physicians to be given a fair score, you need to acknowledge all of the risks, not just the distribution of lesions in the coronary arteries, but every factor that's going to affect health outcomes. But the concern is if you do so, it will then just become a given that poor people have worse health outcomes. And so how do you, and which isn't what you want. What you want people to do is to invest the resources needed to ensure that all people get equitable outcomes, which will require investing extra resources in some people. Some people say that's not fair. Some people say that's the definition of fairness. And so it's a real dilemma. I don't think this has been resolved. The Center for Bioethics has this debate periodically. Do the harms of social risk adjustment outweigh the benefits? And there are really strong feelings on both sides of that issue, even within the Harvard medical and ethics communities.
Is it fair to then say that maybe it's worthwhile to use these algorithms or this information that you've collected, extensive information, as a way to highlight the disparity, but not necessarily to do prognostication? Or is even that a fraught claim?
You're always going to want to do it carefully, but I think there is a way you could do that well. It'd be very hard to know exactly. Now, I've been involved in an on-again, off-again debate with the cardiac surgeons since last summer when our piece was published. One of the things we pointed out is that the Society for Thoracic Surgery has a cardiac surgery risk calculator that has something like 100 input variables, which is much, much better than most of the clinical tools that are out there. One of which is race and ethnicity. And they haven't published their algorithm. But anyone who knows Python coding, unfortunately, my son did this for me. You could just query the algorithm, the website with a bunch of different simulated patients, and you can reverse engineer what the algorithm is. And it turns out it reports that Black patients have a 19% higher operative mortality rate for coronary artery bypass grafting. And it raises a really interesting question. So that gets figured into the algorithm. My colleagues and I were concerned that telling Black people they have a 20% higher risk of dying would scare them away from surgery. The surgeon said, we're ignorant. We don't understand the difference between absolute risk and relative risk. No patient is going to avoid surgery because their risk is 1.2%, not 1%. And so not all 20% risks are created equal. If it's still small, it's still small. And they may be right about that. To which we would say, well, if the race correction is not medically significant, why do you include it? Because that just serves to reify race as an important medical variable, which you've said it's not actually relevant. To which I think they would say, well, if we were to sweep that under the carpet, that would look really bad. You can imagine the New York Times article, expose. Society of Thoracic Surgery knew that Black patients have higher operative mortality and buried the data. They're not going to want to do that. And so I don't know exactly what the right answer is. Part of my response, and I haven't pursued this line of argument, but you could say to them, well, how long have you known this? I suspect they've known since the mid-1990s that Black patients have a 19% higher operative mortality rate. It's like you've known about this for 20 years and you haven't figured out how to fix that. And I suspect, again, this is just my imagination, I would suspect they would say, the factors that account for that are beyond our control. And so therefore we're not responsible. And so they're really, really interesting questions here that are going to require some really subtle thinking about the best way forward.
Yeah, that makes a lot of sense. That's a whole panel discussion you played out in real time on how this might go. The audience should feel free to ask questions. We do have only a couple of minutes left. I do have one or two last questions that I want to ask if no one else has questions. Okay. So my question is around transparency, which Heather alluded to, and like essentially regulatory frameworks in general when it comes to inequities and how these models, which are like making their way into practice, will be validated and assessed. And what are your thoughts on whether we have a sufficient regulatory framework in place, or what needs to be done if not, and how should experts, maybe computational experts, engage with that kind of those kinds of issues?
It's an interesting question because I'm working with others to write a paper about this. The regulation of AI algorithms in healthcare and medicine, because again, there's so many stakeholders that we've mentioned before. Who's responsible? There's, ethical interest, there's medical interest, there's financial interest, there's across the board, everyone has a different incentive, but nobody wants to be held accountable if something goes wrong. So who's actually in charge of regulating this? If we make the FDA or the government or something try to regulate every single algorithm, nothing is ever going to get done and implemented, at least not in a timely manner. And sometimes, maybe the model is sufficiently simple or, has really good data. What if your data is really of the entire population that you're going to be using it on? There shouldn't be any bias that way, or, you have really good ways to kind of test the performance of your model. So maybe in some circumstances, you can have like an internal person who regulates it with the help of others, but, or maybe it's a hospital that regulates it and they have like a board of overseers. We've been thinking about it in terms of like an internal review board in a way. You can have some algorithms or processes that have exceptions and don't really need to be watched very carefully. And then you could have really high risk ones that need to be regulated very heavily. Maybe they're going to be implemented at a greater scale or affect people in a more serious way. And so it's, again, a problem that's not going to be easily solved. There's going to be very strong opinions all across the board. But it is something that we're starting to really think about because there, at least to my knowledge so far, again, I haven't researched it completely, but there's not a lot of true regulation of these things. And that's why we keep finding, issues with them and biases with them. So it'll be a long process, but and hopefully another complex problem we can put our heads together and kind of figure out.
Great. Any closing thoughts, any takeaways for the audience? It seems like one big takeaway for me is to be optimistic and to essentially, and the other thing is to be very creative about the kinds of problems you want to tackle. But any last minute takeaways for audience will be really good.
Don't shy away from the complexity. And these are hard problems, and people are gonna have to do hard work and collect large and complex data sets, because only by doing that are we gonna be able to make progress with these problems.
So I would say that I am optimistic because I think that we have all the tools now to make AI that's good enough to improve patient outcomes, as well as improving on some of the disparities in our healthcare system. I think what's missing, though, is a focus on the outcomes, the impacts, and a lot of the behavioral research that can inform our estimation of the impacts and the implementation of the algorithms.
And I guess I would just say, keep the human in mind. And I know we're very quantitative, computational people. We can forget about that sometimes, but I think keeping in mind who you're doing this for, who this is going to affect, will hopefully drive some of our, decisions and progress in all of these complex issues.
Great. This was excellent, and thank you so much for taking your valuable time and talking to us for 1.5 hours. I learned so much. Exactly, I learned so much from today that I haven't learned in doing computational stuff in a while. Great. I guess, can we just share some of your, maybe your Twitter handle or email if people want to reach out to you? Would that be good? Okay. Great. Thank you all for joining us, and hope this was helpful for you. David's email is in the chat. All of the emails are on the chat.
I'll put mine in a second.
Thank you.
Thanks.
Yeah. Thanks, everybody.
Bye.